Welcome to Louisville Lectures, making learning and teaching easy for residents and students on the go. Join our residents from the University of Louisville as they share the highest yield internal medicine topics in digestible chunks. Hi, this is Dr. Laura Bishop. I am a MedPeds hospitalist here at the University of Louisville and the executive director of Louisville Lectures. And I wanted to bring you kind of a just-in-time series that is focused on the pandemic that is probably on all of our minds right now. And so part one is going to be a lot of background information, and it's just a lot of definitions. So you'll excuse me, I've got a paper here I'm going to read from for this. And then part two is going to be a little more practical application, what has worked for other people in a clinical setting, just so that we can have a little bit of information under our belts by the time that this hits us, hopefully. My disclaimer is that these are the current recommendations that we have at the time. However, they're changing on a daily basis. So I refer everyone back to the CDC website if you should have a person that you suspect of having COVID or an active COVID confirmed case. So you can actually look up the current recommendations for the time. And this is as of 3/14/2020. So my objectives for you today are to really be able to recall coronavirus. And for some of us, virology was a long time ago. Some of us not so long ago, so some of the background behind the virus, and then recognizing some basic public health definitions so you can put the recommendations into place. And hopefully you, at the end of this, will know some symptoms that should alert you to concern about the potential for COVID-19 in your patients. So a little background, the coronavirus is a single-strand RNA virus that is in a protein envelope that's studded with spikes around there. These spikes tend to resemble a halo, so Latin makes this into corona, so they're coronavirus. These spikes actually help the virus enter the cells. So the 2019 initially named novel coronavirus was officially named the SARS-CoV-2 by the World Health Organization, so named because of the severe acute respiratory syndrome coronavirus, and it's 2 because we had the initial SARS virus back in 2002. And I applaud their attempt to name this and reduce stigma by not naming a place, person, or animal. And it causes the coronavirus disease 19. So that's shortened to COVID-19. So SARS-CoV-2 causes COVID-19. This is a beta coronavirus that is very similar to the SARS that we discussed, but also the Middle Eastern Respiratory Syndrome, or MERS, that was emerging in 2012. As with these other zoonotic viruses, SARS-CoV-2 originated in an animal reservoir that was likely a bat and has spilled over to humans and then subsequently developed transmissibility by human-to-human contact. It spreads quickly as droplets and can also be found on stool and surfaces. So quick epidemiology for us. A basic reproduction rate, or an R0, is the likelihood that one infected person is going to spread a virus to how many other people. So for example, a rate of 1 is that for each one person infected, they're likely to spread to one other person. This tends to peter out relatively quickly. For example, our seasonal flu R0 is typically 1.3. Currently, COVID-19 is estimated to be around 2 to 3. So this very high transmissibility is part of why it is spreading so quickly and has now become a pandemic. As you look at the CDC recommendations, a lot of them are going to have these terms. So a couple I wanted to cover really quickly. Self-observation. So this means remaining alert for symptoms such as fever, cough, or difficulty breathing. If they develop, then you would take your temperature, self-isolate, and seek advice by telephone from a healthcare provider or public health department. So this is hopefully what everyone is doing. Every single person should be self-observing for symptoms. Self-monitoring, however, is when you take your temperature twice a day in addition to remaining alert for symptoms. This can either be voluntarily or it can be with delegated supervision. So certain groups of people, typically certain occupations, such as airline pilots or laboratory workers, are actually having their temperatures monitored. So that would be self-monitoring with delegated supervision. And then active monitoring is where you have a state or local public health authority that are actually assuming the responsibility for establishing regular contact with potentially exposed people to assess for the presence of symptoms. So with high-risk exposures, and there's an algorithm for that as well on the CDC website, it should be daily contact from the health department typically with the exposed person. The CDC defines close contact as being within approximately 6 feet or 2 meters of a COVID-19 confirmed case for a prolonged period of time. This typically occurs when caring for, living with, visiting, or sharing a healthcare waiting room or area with a COVID-19 case. Or we could also define close contact as having direct contact with secretions. So if someone coughed in your face and then had COVID-2019 confirmed, you would be a close contact. Isolation refers to the separation of a person or a group of people who are known or reasonably believed to be infected with a communicable disease and are therefore potentially infectious, and they are separated from those who are not infected to prevent the spread of a communicable disease. So in this case, isolation is known but also reasonably believed. So in our healthcare settings, a lot of our patients are being isolated while they're being ruled out for COVID-19. This is different than a quarantine, which in general means a separation of a person or a group of people reasonably believed to have been exposed but are not yet symptomatic. So this is to prevent the spread of the communicable disease. So people who had traveled out of the country were quarantined even without symptoms. Once people develop symptoms, they then become isolated. Social distancing, if you haven't heard it yet, I don't know where you've been living, but it really means maintaining distance from others. And this includes staying out of congregations of people, avoiding mass gatherings, and maintaining a distance from others when possible, preferably at least 6 feet. And the CDC refers to community mitigation strategies as these non-pharmacological interventions that are really the most important response in the absence of a vaccine or treatment. And quickly, I wanted to remind you the pandemic phases. So really investigation when we're trying to trace where breakouts have started and exposures so that we can start to isolate what's going on and what the disease is. Recognition, initiation, acceleration, which would be the peak time of disease, and then deceleration. So who needs to be tested? And I really hesitate to speak in specifics because it is changing on a daily basis. And I think it's really a changing recommendation in every individual community depending upon the availability of tests. So instead, let's talk about who to suspect. Anyone who has fever, dry cough, and in particular absence of nasal congestion, rhinorrhea, sore throat, or chills. Currently, when these are combined with an appropriate travel history or a known exposure, there should be discussion with the health department to determine whether you should test this patient, depending on the availability of tests in your area. I mentioned the absence of nasal congestion, rhinorrhea, sore throat, and chills because these are much more common in influenza than they are in COVID-19. As we have more widely available testing, I assume we'll be testing all patients, but I think your ears should stand up when you have a fever, a dry cough, and someone who has no upper respiratory symptoms in terms of nasal congestion. Currently, we are also considering hospitalized patients that have similar signs and symptoms and no other cause identified for testing as well. And hopefully with an increase in testing, all hospitalized patients with respiratory symptoms and all people who have had close contact with COVID-19 patient within the past 2 weeks will be added to this list. So keep your ears open. You can go to CDC.gov. They have a clinical criteria where you can see who the current definition for patient under investigation includes. And then I want to talk just briefly about the test. So the test that we're currently using is a reverse real-time PCR or an RT-PCR, which is developed by the CDC and is being utilized by local and public health labs. Commercial labs, hospitals, and research labs are currently working on validating their internal tests so that they can utilize these. CDC is also developing a virus and cell culture to allow for further studies, as well as serology tests that are being developed. After testing, the next step that we're going to do is we need to talk about isolating these patients and appropriate disposition and treatment. So stay tuned for that in the next update. So I hope after the end of this talk that you feel better able to tackle the CDC recommendations because you understand the underlying definitions, that you know when to suspect a patient with COVID-19 and whether they qualify as a patient under investigation. So signing off, I want to remind you to keep washing your hands, covering your mouth, using appropriate personal protective equipment, staying apart from others, and staying home if you are sick. Be well. Thanks for listening and learning with us. If you would like more information on this topic, please take a look at our full-size Louisville Lectures, either on louisvillelectures.org, on our YouTube channel, or on our podcast.